this orthopedic practice at HRSM. I'm actually a physiatrist, which is physical medicine rehabilitation, so my focus is more in function, rehabilitation, again, non-operative care, kind of the pre and post guy. Hopefully, if you don't need surgery, we can manage it without it, and if you've had surgery, we still try to manage it after. What we're going to talk about today is this kind of elusive joint, the sacroiliac joint, which most people have not heard about or have heard maybe in passing. This is a big joint in your pelvis, kind of behind your buttocks, and we'll see some diagrams in there and kind of describe some of the anatomy and some of the stuff. So I'm going to be probably the bulk of this, talking about some non-operative kind of options and care and some things that we can do. Then I'm going to get Dr. Aldridge to come in and talk about some of the surgical management of this. So thank you for coming. I really appreciate it.
Hit the on button on the side. Sorry.
I got to turn it on. All right, so that's me in short. I'm born and raised in Atlanta, undergrad in Colorado, and master's at Georgia Tech, and just anyway, I've been all around the place. If you've lived anywhere I've lived, we'll have lots to talk about. Dr. Aldridge, he's New York, born and bred, so that says so yeah, quick poll. Has anybody heard sacroiliac joint or SI joint? Most people are a little familiar with that. Good. All right, so just kind of an overview of what we're going to be talking about tonight. Just the anatomy of the sacroiliac joint, kind of lumbar kind of area or spine. Some characteristics of some of that SI joint dysfunction, or what we see typically with that. How do we diagnose this stuff? What are our treatment options? Not just non-operative treatment options, but also we're going to talk about some of the surgical options. And then obviously, if we have any questions, we're pretty easy to talk to about this stuff. If you got questions in the middle of this, I don't mind answering them. If you don't want to wait till the end, we're, again, very flexible. Low back pain, right? So second to the common cold, this is what brings people to their doctor. It is that common. All of us have some part of this in our lifetimes. Some people it's very mild and it's very manageable, and some people get very severe back pain. It can be very debilitating and very functionally limiting. But all of us, nobody really escapes planet Earth without having some element of degenerative changes, arthritis, back pain, and then again, it's common enough where most people in the world are familiar with that in some respect. And that doesn't mean that this back pain is necessary from your SI joint. I'll clarify. You have lots of different pain generators in your back that can create back pain. One we're looking at today or tonight is specifically this SI joint. Again, low back pain, lots of office visits. Primary docs are really pretty overwhelmed with this stuff. So we try to get into specialists that really work on specifically low back pain. Indirect costs, right? This is taking you out of work, right? Not able to generate money, medical, billing, all these things. 86 billion, that's not a small number. So our spine anatomy, in short, we've got our neck, which is our cervical spine. There's some vertebra up there. Our thoracic spine is where all of our ribs come off. Our lumbar spine is our low back. We typically think of our low back as a lumbar spine. And then we have this pelvis, or this sacrum, and some other components within those wings that are on the sacrum are called your ilium. So we have this sacroiliac joint right in between. And that's along here and along here. And then we have a coccyx that's just below that too, if you've heard of kind of a tailbone. And that's right in the kind of midline. You have disc in between your vertebra. These are our cushions. We all lose some of that cushion as we get older. We all lose some height, right, as we move through our world. There's little tiny joints in our back too called facets. Those get arthritic, like knees, hips, shoulders, and our other places too. We have nerves that are exiting out of these spaces within our spine. Those can get squeezed or pinched on. I'm sure most people have heard of sciatica, right? That's kind of that. And then again, this last segment, this fused segment, or the sacrum, has those same nerves that exit out of those as well. And those little, those nerves can innervate this SI joint, and sometimes we target this SI joint through those sacral nerves as well. And a lot of people, come in and they see me and they say, just, my back hurts. And I say, well, where? My back, or my hips hurt, and they point to their pelvis. And your hips are actually in front, and a little bit more kind of groin, typically for hip pain. So it's important to clarify, or when you see your physician or your specialist, to really be able to describe this stuff. That really helps us out quite a bit than us kind of just trying to kind of figure out. Because if a lot of people take it as face value. If you come in and say, hey, my hips hurt, well, you might lead your doctor down a path that it's not necessarily your hips, right? So I'm kind of trained enough to go, well, I know you say your hips, but where do you point to, or where is that pain located? If people kind of go back and point to their spine, or to the back, or to their buttocks, we do want to look into these places. We also have a little bit of a dividing line kind of belt, right? I ask people, is it above your belt or is it below your belt? And so that helps too, but it's a very complex package. We've got a lot of different, like I say, pain generators and structures within that very small area, and sometimes it's not straightforward. Pictures and cartoons make it look really simple and really easy, but believe me, everybody's backs in here are not this pretty, right? It's part of the package. Okay, so Dan promised me we'd have a video where we can see. All right, so we've been doing this for years and we've never had this work. So this is really exciting. So the highlights there are those sacroiliac joints. Again, you have your ilium, which is your pelvis, or the wings there, and that connects to your sacrum. And those are actually two very big joints, right side and left side, and that is your sacroiliac joints. So let's see that again one time. So we're kind of zooming in through the pelvis. Now this is from the front. And that joint, just like all of our body, is 3D, right? So we have this joint space. Let's see, do I have the line on this? Yeah. So we have this anterior joint space from the front, and then from the back, that is also there. And that's where we access this. We obviously don't go through the front to get to that joint space. We want to go from the back, kind of through the buttocks. So this SI joint anatomy, like I was talking about, we have these two big bones that come together, the iliums attaching to your sacrum to make that sacroiliac joint. There's a very complex ligamentous support and structure in there that holds everything in there, kind of like tape. Over time, those ligaments and some of those connective tissue can get a little laxity, and we oftentimes find a little motion in that SI joint can really flare up and irritate this stuff. And we'll talk a little bit more about some of that patient population that I see that typically get kind of this SI joint issue. It also has a very complex bed of nerves. It's probably that complex, but because it's a cartoon, it's a little overwhelming. What I was trying to say earlier is that there are the big nerves that exit out of the spine, and those are the nerves that tell your muscles how to work, how your skin, how to feel. But there's also little sensory nerves that branch off of these big ones, and those innervate those joints. So when you say, hey, my knee hurts, right? Well, those are little sensory nerves that are telling your brain this stuff bothers you, right? Just like in our SI joint, little sensory nerves that are going to those spaces to say, hey, there's something not right in here, right? Pain is a response we get when something isn't right. It's just when that pain is chronic that our brain is getting a different signal and it's not turning off. On top of those ligaments and these complex kind of web of nerves in here, we have a lot of muscles that stabilize our pelvis too. We have really important butt muscles, right? Everybody has to work on their butt muscles forever. That's a really important one. And then we have these lumbar muscles that also come down too, and I'm sure everybody's heard of their core, right? Core musculature, or core stabilization. That's really important for this stuff as well. All right, so way more common than people realize. This sacroiliac joint can get in the way. We do see this as part of kind of our normal day-to-day progression with degenerative changes. It's much more common when people have had a fusion in their lumbar spine. So a lot of times people will get a fusion for sciatica or a disc that's pushed out and irritating some of these structures, and the surgeon gets in there and fixes the problem at hand. But then 2 years, 5 years, 10 years later, we get patients that come in and say, I'm really having a lot of below the belt kind of buttock pain, maybe a little radiation kind of down and back into the thighs. And it's because when you have a fusion in your lumbar spine, those bottom segments that are fused don't move anymore, and that's on purpose, right? The surgeon has done that on purpose to fix the problem that it was. But over time, we get this adjacent level kind of trouble or adjacent level disease where the levels above your fusion and the levels below your fusion start getting a little more wear and tear in them. Does that make sense? That's an important concept, I think, to hear. So we see this, right? Symptomatic patients with this SI pain, up to 40-something% of those lumbar fusions will at some point in time have maybe some SI irritation, right, or some SI joint dysfunction. Some common causes of SI joint pain or SI joint dysfunction. Trauma is a pretty easy one to wrap our heads around. Think of car accidents, right? You are slamming on that brake pedal, sliding into the back of another car. All that energy gets pushed up through the foot, through the ankle, the knee, the hip, right into your pelvis, which is your SI joint, right? Falls, this is common when people will come in and they're going into their garage and it's too dark. They miss the bottom step or think they've already gotten to the bottom, or they think they have another step left, right, and they don't, and they are kind of outstretched leg, landing on that, and that same mechanism is pushing right up into their pelvis, and that can be very irritating for this stuff too. Repetitive injury. We see construction workers, right? So sometimes people will be, hey, Frank is the one who always does the jackhammer, and he's great at it, right? But 10 years later, Frank has got a really awful SI problem, right, that is not improving, and it's these chronic issues. So we do need to be careful with repetitive injuries in there too. Lifting's kind of understandable. Usually we see that with disc herniation, sciatica, and other stuff too. But pregnancy is an interesting one, right? So for the women in the room, and I even see this, you don't have to have had children, right? But we find that women kind of middle age, maybe that 4th to 7th decade, if they've had babies in the past, as you are pregnant, your body is releasing hormones to give you some laxity within your pelvis, because you've got to be able to put a baby through that space, right? After you've already had that delivery, your pelvis will tighten back up in here, but it's never like it was initially, right? If you think about it like a rubber band, stretch it enough times, it's never that tight rubber band it was initially, because it's already been kind of stretched out a few times. So in those later decades, we see a little bit of that laxity in that SI joint, and then it just really starts irritating gradually. Childbirth is a little different, right? So these are these young moms who have had either this stretch injury, or they've had this delivery of a baby that's maybe too big, right, to pass through those canals, and you get this kind of this stretching effect, and that can irritate SI joints quite a bit too. So a lot of times even in pregnancy, we'll get an SI belt or something that can really kind of stabilize some of these pregnant moms, their pelvises, and that just kind of holds things a little bit together and they're tighter. And try to limit some of that motion that's within that SI joint, because remember, they've got hormones going that are making all that stuff a little lax or a little loose. So we see this kind of in all of those stages of, for women, as far as with pregnancy, during childbirth, and as even older in life, even as older moms and grandmas. Degenerative changes are normal. We expect these things over time. It just comes with, it's the gift that keeps on giving, right? Being on planet Earth, we all build this. And some more than others, right? Some people find that, hey, my shoulders are what end up giving me more trouble than, you know, my hips or my knees. Or you have a neighbor and it's like, hey, it's all knees for them and their shoulders are great, right? And then the next neighbor over, it's like, hey, my knees are great, but my shoulders are awful. And everybody's a little different in here, and that doesn't necessarily mean what you did in your previous life, right? You know, as far as work or manual labor or, you know, things like that. This stuff can just kind of come with the package. So we do really talk about strengthening muscles, strengthening, you know, your ability to kind of keep up with this stuff, because we have no control over your arthritis, right? We have medicines that help with some of those signals and some of that inflammation or some of those changes that come with that time, but we can't turn it off. There's no off switch to this. And you know, we kind of joke, people say, well, what if I just, you know, was in space kind of floating around, right? Well, then I wouldn't have any arthritis. That's true, but now you won't have any muscles or bones either, because you need gravity to push off of. Those are forces that keep our bones strong, right? And they keep our muscles strong, but the trade-off is we develop arthritis. So no magic pill, right? For any of this. So a very common presentation of sacroiliac joint dysfunction or sacroiliac joint pain can kind of come in a couple of different shades. Most commonly, we are seeing it just like this. You know, we have this Thornton finger sign, which I think is on another slide there. But if I said, point to me where this hurts, and people go right there, right in that little dimple, right in your lower back, right, kind of about belt line, maybe a little lower than belt line. Some people get a little bit more in front and through here. Remember, this is a 3D structure, right? It doesn't have to just hurt in the back. It can hurt on the side, it can hurt in front. But more common than not, it is going to be right in kind of this buttock area, and we do occasionally see some of that radiation kind of down back into the thigh. A little more uncommon to get some of that radiation below the knee, but that can happen. Now this is really important because this is also hip joint arthritis, right? Groin pain can be coming from a hip joint. This can be sciatica, right? So what I'm trying to say is that this SI joint can mimic a lot of other stuff too. And so that's where sometimes it's difficult to really pinpoint, you know, some of these things. It's also different than a typical joint, a big joint we have in our body, like a shoulder, hip, or a knee. This joint sometimes can come with tingling, burning, stabbing, pins and needles, almost like a neuropathic type of pain with that. You know, your knee joint, when it gets arthritis and it hurts, it doesn't typically sting or tingle or burn or stab. And everybody, again, feels pain a little differently. But it's very interesting for this joint because we've got all that complex nervous, you know, kind of connection in there. This can feel like a pinched nerve in your back, like a sciatica. This can feel like hip joint arthritis. And so that's, you know, my job to make sure we're moving through this path as well as we can. Yes, sir.
I understand you're making a distinction between sciatica and SI joint dysfunction. Could you explain the difference for me?
Sure. So your sciatica is going to be these lumbar discs we were talking about earlier, and you've got your nerves running through your spinal cord and exiting out at these levels.
Yeah.
When you have a disc pushing into those nerves, like pinching a nerve, you get a sciatica, which can be, you know, shooting pain all the way down into your leg, into your foot, right? Now that can also come with weakness, debility, but that's usually described as electricity, right? You know, hot poker, ice pick, electrical type of pain. SI joint pain can present similarly to that, but usually there is also a component of, you know, buttock or starting in kind of that dimple area in there, and that's where, you know, physical exam helps with this stuff as well. And imaging. Imaging is very helpful for us for these things too. Did that answer your question?
Yes.
Okay. So anyway, this was a study that was done, which was excellent because it took a bunch of patients and said, all right, where is, you know, you've got SI pain, where do you feel it? And then all these little X's here are where these people feel this type of pain. So you just see it is it's bigger than just, you know, X marks the spot right here in this area. And what's also important about that is that I get a lot of patients who have already seen their primary doctor or an orthopedic doctor or another doctor, and they're really frustrated by the time they see me because everybody's told them something different. Oh, that's your hip joint. Oh, no, that's sciatica. That's from your lumbar spine. Or, oh, you just pulled a muscle in your butt, right? Or your hamstring, is strained. And so by the time they get me, it's they've already gone through some of this other stuff, and that can just be very frustrating. You can imagine it being even more frustrating if somebody ends up getting a hip replacement and it's not their hip, right? So I see these things as well. Or even worse, a lumbar fusion when it wasn't necessarily their lumbar spine, right? And I'm in an orthopedic practice. Surgeons are surgeons, right? That's what they're trained to do, and that's what they want to do. But you also have to realize we're all biased, right, for kind of what we do. So we need to sometimes get a second opinion, right, and have somebody else look at this stuff and really make sure everybody's on the same page with that. This is complex. It can be very confusing and frustrating, which comes with that. Yes, ma'am?
Fusion, would kyphoplasty?
I would not consider that fusion. That's just a compression fracture, and we're putting cement back in there to stabilize that. Fusion is screws and rods and like a scaffolding basically for your back.
Is that the kyphoplasty? Could that procedure be misdiagnosed for?
No, compression fracture. Yes, if you've got a compression fracture, there is no doubting that, right? That's very obvious on imaging because you've got it's very visible, right? Pain syndromes sometimes are not as obvious, right? It's what you feel, right? And that can be very hard because we can get 10 of you in this room and all 10 of you describe that a little differently, right? And sometimes these things aren't as obvious on imaging, right? If we're talking about just inflammation, wear and tear. Broken bones are pretty obvious on imaging. Somebody have a question? This is where I come in. I am a function doctor, right? So I am trying to optimize everybody's function when they walk through my door. Any of these things can be debilitating enough where they're taking you off your normal routine and your rhythm. It's just disturbing enough. Common for this SI joint is, again, inability to stand for long periods of time, or if you see people kind of shifting one side to the other, trouble walking, again, recreating some of that buttock pain with steps and pressure into your legs. Again, hamstring, right? See that third one there? That can mimic, kind of a hamstring strain, or you just say, my hamstring hurts, what's going on here? And you might have 3 doctors all say, well, that's just your muscle, right? You just, you were playing kickball too hard or something, right? And you go, well, I don't play kickball, what's going on here? Just go home, sleep it off, or, a little therapy or something. I mean, we use all of those tools as well. Nothing's worse than a disturbed sleep pattern, right? When people come in and say, I have not slept in forever, and they just, you can tell, right? They're worn out, they're drained, they've got no gas in their tank. And guess what makes pain worse? Not sleeping, right? It really ramps everything up, and that can be very, very hard. Sitting patterns, the same idea as kind of that standing thing. You see people in a seat, on their right butt cheek, and then they're on their left butt cheek, and then they're, so it's just really uncomfortable, and you can kind of tell that because they can't really find a comfy spot. And then, pain going from sitting to standing. And again, a lot of these things we're talking about in here do mimic some of these other pain generators and these other painful conditions, but these are some really common ones we see with SI joint. And then ascending stairs, that same idea of pushing weight or pushing power into your foot to lift it up, that puts pressure right into that SI area, and that can recreate some of that. So, how do we diagnose this stuff? Again, I think you do need to have your doctor be semi-familiar with this stuff too. I think a lot of docs, like I was talking about before, hey, the guy who gets the hip replaced when it's not their hip, or the person that gets their lumbar fused when it's not necessarily their lumbar spine. We got to look at the stuff kind of as the big picture, right? And that's where we do want to use some imaging to make sure that we're not missing something big within that. It is not usually part of this normal workup. And so so again, I get patients that have come in and they've already seen their primary doctor, their physical therapist, their chiropractor, an orthopedic doctor, and nobody's on the same page. That's really frustrating as a patient. But it is misdiagnosed, it's overlooked because again, not many people are kind of honing in on that of, hey, could this be what is causing this pain? And then again, that referral pattern or that pain can be very similar to your hip and to your lumbar spine. And I think, really importantly, right, proper diagnosis, right, can limit some of those unnecessary surgeries. And that's really critical here. And then again, just like I was saying, most physicians are not necessarily trained to look into that as maybe being a pain generator. So what we have are some specific diagnostic criteria. When I see you in the office and I start moving legs around and moving bodies around and start pushing in certain places, I'm trying to work myself down a path of, are we diagnosing a hip problem? Are we diagnosing a SI problem? Are we diagnosing a lumbar spine problem? This first picture here on this far left, again, that's that Fortin finger sign. You go, hey, where do you hurt? And people can, and this isn't 100%, right? None of these are 100%, but an overwhelming majority of people go, yes, it's right there, right on that spot. We do some provocative testing, and that's essentially, and there's many ways to do that, but we are wedging kind of that SI joint and kind of trying to either recreate some of that similar pain, and same idea when we put pressure in through that joint, we can recreate some of that pain. That helps us kind of go down the right path with this too. Imaging that'll be on the next slide in here too. That helps out, and that's also important to rule out other stuff too, right? If I think it's your SI joint, and we don't have an MRI of your lumbar spine, I'm going to order that because I also want to make sure that this isn't a disc herniation that's recreating this same referral pain pattern that's very similar to this SI joint, right? So that's important for me to make sure we're not missing something within that. And looking at your spinal cord is really important because that's a neural structure that if that's getting squeezed or injured enough, well, those are time-sensitive issues. SI joint it's just a joint, right? We're not going to be worse off necessarily if we miss that one on the first time around. But if you've got a disc herniation pushing into nerves and I miss that, well, that's time that you've had with this nerve getting pinched or squeezed, which is time is what? Time is tissue. Tissue is time, something like that. Anyway, there's sayings in medicine, right? These are things we don't want to miss. We want to make sure we're catching this stuff so you don't end up developing weakness, right? Or a muscle that doesn't fire anymore because that nerve is getting pushed on. My part in this is injections, right? So I do more of the interventional side of these things. A big part of my practice is me being able to put a needle or medicine into a very specific place. This big tube that's over this doctor here is an x-ray. You can see the screen behind that. That is allowing that doctor to see exactly where that needle is going into, and that is called guidance or fluoroscopy guidance. And we want to make sure that if we are doing these shots, we are directing these needles in very specific places, so we've got confidence that it is in the right spot, and that if it does help, we know because it's in that right area. And that's important. We don't want anybody getting these injections blind, right? Meaning we're just kind of, hey, that is where it hurts, and let's put the shot in there. That's a trigger point, right? So that's medicine going into muscles, and we do those things as well. But really, therapeutic and diagnostic purposes, we want to get you under the X-ray and make sure this medicine is getting into the right spot. Again, you're going to keep seeing this same picture over and over. Fortin, that's the guy who made this up. Not made this up. This is his name on that diagnostic, kind of criteria, and that is important. I keep bringing it up because overwhelming majority of people, say, hey, I've got this spot right here. Yeah, it might radiate or it might, kind of move around a little bit, but it's very consistent, kind of right over kind of those dimples at the top of the buttocks here. This bottom part here is kind of what I was talking about before. This is the above the belt, below the belt type of thing, right? So below that L5, which is your very bottom level of your lumbar spine, we consider that sacroiliac joint as being one of your pain generators. Above that L5 or above the belt, we're still considering this lumbar spine. But remember that picture with all those little X's on it? There were still X's that were still above that belt and above that area. So we still need to go kind of through this stuff very carefully. Some provocative tests that we do. I don't do every one of these, but we do want to have we do want to be able to reproduce these things, and so we try to put through some of those maneuvers so we can recreate some of this pain, and that gives us some confidence that the diagnosis is correct too. And you can see in most of these pictures, we are wedging down on those SI joints, which are on either side here, and you can see how we're pushing into the pelvis to put pressure into that. We're doing distraction or pushing on the front of your pelvis to see if that recreates some of this. This Faber is typically what I do, and I have you cross your leg over, and I push down on your knee, and are we recreating some of that pain in front, or hip, right? Or are we recreating some of that pain more buttock? And then compression, that's self-explanatory, right? We're kind of on our side, pushing down on our pelvis here, and are we recreating that same type of pain that is in that joint there too? Okay, so again with the injection, that really gives me a really good idea on if this is your pain generator, or if this is where this is coming from, where this pain is coming from. Even if the injection lasts for a very short period of time, it still gives me great information. Obviously, when we do these shots, I'm looking for a very big therapeutic response, right? A lot of pain relief. But I'm also looking at a diagnostic response, right? Is this medicine turning off what we want it to turn off? And if it's not, I need to be looking at other pain generators in there, because there are a bunch. Again, I'll repeat that again. We do this under fluoroscopy or guidance, because we want to make sure that when that needle goes into that space, that we are confident that this is where that medicine is located. We put a mixture of some numbing medicine that's called Marcaine, or it's a long-acting numbing medicine. And then I'm always mixing some steroid within that as well. The numbing medicine gives me good information because that turns things off pretty fast. And there's a little honeymoon period in there where it maybe lasts for 6, 8, 10 hours, kind of the rest of the day. That steroid always usually takes a few days in there to kick in. If I'm going to be putting a needle into your SI joint, you would want me to put a little steroid in there so you don't have to come to me a week later and say, hey, that was great, but it's back, it's there. I would rather put numbing medicine and some steroid in there so when you come back and see me, you say, hey, that did help, and it's still helping, right? That's kind of the goal here with some of these injections. I don't want to see you any more than you want to see me, over and over again, right? The less you see me, the better for you. So if I can put some medicine into those spaces and really turn things off pretty well, we're happy. Usually these injections, I'd say on average, maybe last around 3 to 6 months, typically. And that's with a little steroid shot. Pain relief when we do these shots, so the diagnostic part of it, is this providing 50% or better relief, or is it not quite providing at 50%, or is it less than that, right? So these are some diagnostic criteria that we need to meet. I have people do their normal stuff, right? Getting in and out of the car, right, is an easy one, right? Getting up and down your steps, to your house. Just getting off the kind of exam table or the procedure room and walking down the hall, right? I'm kind of walking with you and asking you, hey, are you noticing any difference, right? Sometimes that numbing medicine can be that quick. But you don't have to go, to the gym and lift a bunch of weights to test this stuff out, right? It's just kind of normal basics. All right, so what treatments have you tried to address your pain? Me on the conservative side of this, we do it all, except for obviously that bottom one there, that lumbar fusion. Is everybody supposed to have like a clicker, Dan? Is this supposed to be like a clicker thing where everybody has their 2 cents and then like we see what the response is for the room or something?
I don't know.
Okay, anyway. So, sometimes we do like a tally, of patients.
That'd be cool.
Anyway, we use all of these things to help this stuff out. Medications, usually in the form of anti-inflammatories, when we're talking about inflammation with this. Tylenol is a good pain medicine, doesn't really do much for inflammation, but we still want to utilize that, especially if you're on a blood thinner, or if you have issues with your kidneys, or if you've got bad reflux disease. We're kind of limited to Tylenol with some of those things. We obviously have other medications as well, stronger pain medicines too. That's, opioids are not ideal for really any of this stuff in here. We just kind of end up giving you another problem. They do work really well for a very short period of time, but we do create another issue in there as well. I will sometimes use a nerve pain medicine if you've got a lot of that burning, stabbing, tingling, pins and needles. Gabapentin, most of y'all have maybe heard of that medicine, or Neurontin. It's actually a seizure medicine we use to stabilize those nerves, and that usually does very well too. Most medications do come with some side effects though, right? So sometimes we're limited with some of these, but we do want to utilize them. They are effective, they can help out. And I'm all for topical medicines too. Heat, ice, lidocaines, biofreeze, aspercreams. Simple, easy topical medicines are very safe. They're also maybe not as effective, right? The dangerous stuff is very effective, right? But there's trade-offs with all of this stuff. Physical therapy is an important part of this. That is not only just to strengthen cores and buttocks and the muscles around these things, but we also work on your mechanics, right? How are you walking? Or if you're walking, 60-40 right on the side, well, you're throwing off a bunch of other stuff as well, right? So it's not uncommon. People come in and say, this was hurting, but now my knee's hurting, right? Or now my ankle's hurting, or I feel like I'm falling to pieces. And then I watch them walk, and they're all out of whack. So this time of year, I really encourage a lot of people to get into the water. Right, pool is a very safe place to work on that 50-50, right, on kind of both sides, and that's just the mechanics of it. We want to make sure that we're addressing these things, not just at kind of the root cause of it, but it's the whole package. Right, so physical therapy can be very beneficial, and a lot of times we will get people into therapies with maybe a little medicine, and they come back to me maybe a month later and say, that did the trick, right? I don't need shots, I don't need more medicines, I don't need more interventions. That really helped out. Physical therapy also is going to have other tools as well. We try dry needling, we do TENS units, they've got a bunch of tools in their toolbox as well that we want to utilize and try. Because not everything works for everybody every time. Right? So we want to kind of move this stuff around. Chiropractic can be beneficial in this stuff as well. That's more of a manipulative medicine, right? Or a manual manipulative medicine, where you're going to them and hopefully they're going to be bending, twisting, pushing, pulling, on things to either get stuff back in line or just adjustments to help these things out. I'm not a huge proponent of chiropractic. I don't take that away from people. I get people who come in and say, that's the only thing that's working. I'm not going to take that away from them. I prefer the physical therapy route because it kind of puts it into your lap, right? It's like, hey, this is the homework that you need to be doing when you get home and work on this stuff, not just with the therapist. Chiropractic care can get very expensive very quickly if you go multiple times a week or if you're going with some frequency. Again, I like the physical therapy because there's an end date there, right? And there's a goal with, okay, how do we put this stuff together of what we need to do at home to keep up with the pace of this. The injections, we had talked about that. That is something we want to utilize in addition to all of these other things as well. And then, again, lumbar fusion, I'm not going to talk about it because I'm not a surgeon. Everybody kind of knows what it is. Yes, ma'am?
How many times can you have injections? Because it is a steroid, right?
Correct, yeah. So we do worry about the burden of steroids on your system. It's my job to make sure we're not overdoing that. On the surface, typically that's about 4 steroid injections into that area for the 12-month rolling period, right? So if it's May, right, and we did, 2 injections this summer, and we did one in the fall. Well, we still got to make it back around, to the summertime before really overwhelming you with shots. I'm very conservative with that as well. Some docs say, well, you can have 4 here and 4 here and 4 here and 4, different places, right? But we still need to keep an eye out on how much steroid we're giving you. I also tell patients, we kind of want to save that shot for when it's bad enough, right? These shots are not prophylactic, right? They don't work in a sense of it's going to prevent it from flaring up when I go on my trip, so to speak, right? A lot of people come in and tell me that, say, everything's fine, but I'm just worried that it's going to aggravate. The shots don't really work in that respect. They work really well, unfortunately, when you're in a lot of pain, right? The steroid in that shot needs something to work on, right? So it needs some inflammatory kind of cascade that's going on that's going to turn a lot of those signals down. So that's always, a good discussion with patients of, well, what's the right timing for this? And my typical response is, I don't want you crawling in here, and I don't want you skipping in here either, right? We want to catch it when it's bad, right? But I want you still to be able to be functional. You got to dress, you got to bathe, you got to toilet, you got to do all the basics. And if that is getting in the way, then it's time to do a shot, right? It's time to put some medicine back in those places. Again, this is everything we're working on in here on the conservative route. We use medicines, and I'm a less is more kind of doc, right? I'm really not trying to overwhelm people with medicines, but that's a great tool we have for Western medicine. But just everybody needs to know that medicines come with side effects, right? They come with some baggage. Again, chiropractic is great, physical therapy is great. That SI belt I was talking about earlier in this lecture, we will sometimes prescribe that or provide that for patients. It sits a little lower than a normal belt, and it really squeezes in on your pelvis. Sometimes that can be cumbersome. Some people don't love that all the time, but it catches it when kind of they need it. Hey, I'm going to be out in the yard, right? Or I'm going to be around the house, doing some things, and we can get a little belt on for those times. Different than a lumbar belt, right? A lot of people wear to support. We don't love those because that takes away the muscles that you have underneath it. And so people wear those belts, and that's okay, right? You can do it for brief periods of time if you're going to be lifting, pushing, pulling, bending, twisting. But for people who wear those routinely kind of day to day, you take it off and you kind of feel naked, right? You feel like, hey, I don't have any support in here anymore, and then you kind of put it right back on. And then you get into kind of a rut of, I can't take it off now because it hurts, right? And it's because you have no strength underneath it. So we've got to work really hard at keeping cores and these muscles around here as strong as possible. This last part here, this radiofrequency ablation, these big nerves come out of these holes here. And like I was saying earlier, there's these little sensory nerves that run across. They run across the pelvis or the sacrum, and they innervate this joint. So we do have steroid injections for these places, and that's a little easier and quicker because it's just one shot. This radiofrequency ablation is usually when I start talking to patients if they've had some of these steroid shots and they say, hey, this really helps, it just doesn't maybe last very long, right? We don't get our 3 to 6 months, right? Or we don't really get an extended period of time out of this. I talk about this radiofrequency ablation where we first block the little sensory nerves that go to that joint with just some numbing medicine, no steroid within that. And I have a fair bit of patients that can't do steroid either, and we have to kind of defer over to this RF ablation. But before we do any ablation, we are diagnostically putting numbing medicine around the little sensory nerves and see, can we turn off a lot of this pain by blocking those little nerves? And with that, we're looking for really pretty big numbers, 80% pain reduction or better. And that gives us a lot of confidence that, hey, this is where this pain is coming from. So if we do an ablation, which you maybe have heard that before. Have you all heard of ablation? Or you've heard people call, hey, they burned my nerves. Right? We're actually not burning anything, but we put a radiofrequency current on top of those nerves, which disrupts their signal, but all these little sensory nerves grow back, right? So if we do these ablations, we maybe expect 6 to 12 months of relief, right? Because those nerves are going to find their way back. And that, again, that's just another way we go after this same structure. SI belt, I've probably talked a little too much about that. I'm going to stop boring you all with those things too. Physical therapy, again, we talked about this stuff too. Again, just reiterating, body mechanics are really important. All of those activities of daily living, dressing, bathing, grooming, hygiene, basics. Your gait, right? Balance, right? That is a huge part of your core, right? If you do not have a strong core, you do not have great balance. That is something that comes with time. As we get miles under our belt, balances and gaits get thrown off. We have to always be working on these things. Especially as we get older too, sometimes inner ears don't work quite right, and we get a little unsteady or off balance, regardless of your musculoskeletal system, but now neurologically, sometimes we get a little unsteady. And you need to have a strong core and strong legs and a strong butt if you do get a little off balance, right? That's the stuff that catches you if you were to stumble. People who don't have that strength in through here, it takes a little push and then you're over, right? We all fall. We just can't have any big falls, right? That's when you break a bone, right? So we really got to work on those things. And again, physical therapy is a big part of that. These SI joint injections I was just talking about at length. Again, I use more than just the local anesthetic. We do some steroids too. That radiofrequency ablation, again, kind of burning. We're actually not burning anything. We just create a current in there on these 4 sensory nerves. So when I do these medial branch blocks, I put a needle here, 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 and here. So this is this little branch that comes off L5, S1, S2, and S3. All of these nerves in here feed into that joint and provide its sensation, right, or pain. Right? So I'm trying to block those, and then if that does really well, we do burn these nerves, or we do that radiofrequency ablation, or RFA, and that temporarily turns those signals off pretty well. These nerves regenerate, right, and we want them to regenerate. I do this stuff, because it is, temporary. Some people go, it's, or I say, hey, it's going to help maybe 3 to 6 months. And they go, oh, that's it. Like, but yes, but we can do this stuff again too. And if it doesn't help, we go a different direction. Or if this medicine doesn't work, we try something else. I mean, my job is to surround you with as many tools as I can. The surgeon is either we're going to fuse it or we're not. There's only one kind of option in there. So anyway, it's important to go through these conservative measures first. So if you do get to the surgeon, you can say, all right, I've done the therapies, I've done the medicines, I've done the shots, I've checked all these other boxes off. So you also feel confident that we're doing this at the right speed, not jumping ahead and getting a hip replaced when maybe we didn't follow through some of that other stuff. I'm going to let Dr. Aldridge talk about really what we're here for today with iFuse, their implant system. And this is the surgical approach of stabilizing that SI joint. Dr. Aldridge, the floor is yours. And after this, if anybody's got questions for me, please come.
So they give me one slide. Short and sweet. So for people who fail Dr. Bradley's pain management techniques, if we can confirm that it is your sacroiliac joint, that's the problem. These injections that Dr. Bradley gives into that joint, number one, have to be in the joint. So you need someone who's very skilled at getting the needle in there. This is a very small joint. Because if they don't get in the joint and they numb up a nerve or some other spot, and you get good pain relief, and then fuse your joint, well, guess what? You're not going to get any pain relief from the operation. The second part is you have to be honest with yourself what kind of pain relief you get from these diagnostic injections. If you don't really are not honest that you get good pain relief from the injections, surgery is not going to work very well either. And the most important thing is, obviously make sure you're operating on the right thing that's causing the patient the problem. And so, as Dr. Bradley said, the most common things that we see, people have hip replacements, spinal fusions that don't fix the problem, and then we end up doing the SI joint and it fixes the problem, or vice versa. So the procedure was developed, it's about 10 years ago in the community. I've been doing it for about 10 years. And what we do is we put 3 little metal pegs across the joint to fuse it. And we do it through a percutaneous system. Scissors usually about that big, about 2 of them to make sure it goes in the right spot. And I also use some neural monitoring, right? Monitor your nerves, make sure these things are not getting close to the nerves. So we don't want them to be touching any of your nerves, otherwise you're gonna have a radiculopathy, even though we may fix your SI joint problem. They've actually improved the design. They used to be solid pegs with just a coating on it, just like a total hip prosthesis. And then they developed them, the little fenestrations, or the little holes through the bone, so the bone can grow through them. So is this a video? Just hit forward again. Just click. So once again, you'll notice stabilizing the ligaments. Sometimes you have inflammation, chronic degeneration, abnormal motion, causes pain. And that can be just from wear and tear, it can be from trauma. And these are the pegs being placed across the SI joint to stabilize it, to fuse it, to stop the motion, to hopefully give you good pain relief. And it takes about that long to put it in. So the system or the procedure is basically identify the SI joint, get you in a good position so I can see you with the X-ray machines. We then use the X-ray machines to make sure the guide pin goes to where we want the final implant to go. We then drill a hole and kind of create a path for the implant, and then I get a big hammer out and we knock it across the joint. Just like a golf ball.
Wow.
Dr. Bradley is the good golfer, I'm the bad golfer. So this is the design. It's triangular. Think of wheels. You know, wheels are on your car and bicycles. Because why? Because they can create a nice low friction motion to get you moving. Well, if you're trying to stop motion, a wheel or round implant is probably the worst design possible to stop that motion. So a smarter guy than myself, probably was a caveman beforehand, started with a triangle construct, stop the rotation or motion. It also creates a lot of surface area for the bone to grow onto. And then they added little fenestrations or little holes to then allow the bone not only to grow onto it, but through it, to create more path to get a good fusion to stop the motion there. To date, since November 2021, 60,000 procedures have been performed. It's been over 10 years. There's over 100 plus publications, not by myself, by other people, about the safety and effectiveness of the procedure. My general experience has been very positive over the past 10 years. I would say the only failures I've had are the ones where the patients come back to me and say, well, I really didn't have good pain relief from the diagnostic injections, and this isn't really working for me either. So it would have been nice if they were honest before the operation than after. The good thing about it is that, you know, pre-op people have pretty high pain level, and then they drop down after the operation, and then the pain relief is maintained over a long period of time. This is 5 years of data. People still have, they're satisfied, they still have good pain relief, and their function is still maintained. So if you have the right problem, the right diagnosis, the right operation, and you failed all the non-operative conditions, you can have good pain relief that should last for a while. If not, hopefully forever. The other good thing is still a very high patient satisfaction, 91%. I usually like 90 or plus when I tell patients I want to operate on them for a condition, and this fits into that criteria of having very successful operation and a lot of happy patients. Once again, we still had good maintenance of the relief of pain and the improvement in the functionality, and that's what all these that was Western Disability Index, VS, SI joint pain. These are all scales to see how's your pain, how's your function, and how's it maintained over that certain period. We have same kind of scales for hip replacements, knee replacements, and they kind of have the same graph period where you have patients with bad pain, you do the operation, they have good function, return, pain relief, and it's maintained for a very long period of time. And as I said, same things, 5 years later, people are still very happy, still having good scores on these disability and functionality scores testing. So this gives indications and contraindications for the iFuse. If you're interested, you can go to the website and see all the studies that we're quickly going through here today in more detail. You can actually link them onto the real studies and read the whole paper if you want. Some of them are very fascinating, some are not so fascinating. So in summary, if you have low back pain, you know, the initial screener is typically your primary care doctor, which is usually pretty good. But obviously, someone like Dr. Bradley is probably the best person because he doesn't want to operate on you right away. And generally, if you come to me, I say, well, I don't want to operate on you right away either. I want you to see what Dr. Bradley can do for you. Because he can keep probably at 80–90% of my patients in a functional, not pain-free, but functional level before they really think they want to have surgery. And I would say, of 100 people come in office with back pain, I'll probably operate on 1 or 2. So many people, the back pain is temporary, it waxes and wanes. If you wait long enough, where you get the right treatment, the pain will really get to a point that you don't think you want or need surgery. Obviously, surgeries, not in this instance, but for spinal surgery, things that are emergency are, you know, our bladder incontinence that develops, foot drops, muscle weakness, things that need to be reversed if you have pressure on the nerves. Those are emergencies. Those things Dr. Bradley can't fix. But most of just the generic back pain that we see, he can get you better. But for the people who don't do well or fail the treatment over time, the SI joint fusion is a great operation for those who have a real problem with the SI joint that we improve. As you can see from the studies 5 years out, the pain scores, the functionality all seem to be maintained in patients who are good candidates for this procedure. So, you want to see Dr. Bradley? I recommend first. Call the number. If you want to bypass Dr. Bradley, I'll be happy to see you too. Probably going to see Dr. Bradley within a couple minutes. Yes, sir.
How many of these have you done? I may have missed it. Have you personally done?
Me personally? You guys know?
I think it's right around 300. 300, yeah.
You lose track. Not of people, but just the number of procedures.
30.
You did mine 8 years ago and it worked nicely and it's still working nicely.
There you go.
We're not paying her, I promise.
You should go with dance for us.
I'm Dr. Bradley's patient for the other side now.
So eventually he'll bring you over to me. But, I mean, it is a good procedure, but like I said, you really want to see someone like Dr. Bradley for a while and make sure that it is the right diagnosis and you're not comfortable enough getting treatment or relief from the non-operative stuff.
Well, I got a